Mia holds a BA degree in International Service and English and has a major's degree in Clinical Mental Health Counseling from Valparaiso University out of Indiana. She is a member of the Motivational Interviewing Network of Trainers, and her areas of focus are integration of behavioral health into primary care, promoting positive health behavior change, trauma-informed and sensitive practices, and social determinants of health. So, thank you for coming.
Thank you for having me. And thank you for joining us today over this delicious lunch. I had a little taste of it earlier, so that was a welcome addition. I don't always get to talk while people are being happily and contentedly fed, so that helps. Just a little bit of background about myself. I'm trained and practiced as a clinical mental health counselor. I've done community mental health, inpatient psychiatric care, outpatient services. And about 10 years ago, I was living and working in Chicago and decided to move back to Wisconsin, where I'm originally from, right outside the Madison area. And I took a position doing this new thing that was called integrated care. So I was embedded in a primary care clinic, and a big part of my role was to screen patients for mental health conditions, but most routinely we were screening them for problematic alcohol use. And this was part of a grant-funded initiative, and as part of that, I was trained in motivational interviewing. And when I first was introduced to it, I certainly had a skeptical mind. I thought to myself, you know what, I already know how to talk to people. I've been in this field, I've been talking to people in crisis, out of crisis, angry people, difficult people. I know how to do that. And so I listened to the motivational interviewing training, and some of it sounded useful, and a lot of it mapped on to sort of my already existing beliefs about how to work with people. And so I, dutifully attended the training and went home and put all the materials in a folder and went and put the folder on my shelf and kind of didn't consider it again for a while. Well, in this position that I was in, we were screening all the patients who came for a primary care visit for problematic alcohol use. And then, depending on the results of their screen, surprise, they got a conversation with me that day added onto their visit. I can tell you, that wasn't the most delightful thing for them. They weren't super excited to be having that conversation. And, the position that I took, thinking like, oh, I'm gonna go do some prevention, it'll be kind of less intense than this inpatient world I've been living in, wasn't super fulfilling. I wasn't being very successful, and I was starting to get a little burned out pretty quick. In addition to that, I had to capture audio recordings of myself with the patients, random samples, and submit them for fidelity testing. And I was getting feedback that I wasn't really doing much that looked like motivational interviewing. It was sort of motivational interviewing adjacent, but it really wasn't aligned with motivational interviewing. And so that's when I, being sort of the dutiful type A people pleaser that I am, that's when I really took to circling back around and taking some of the learnings a little more seriously and really trying to implement them in the work I was doing with patients. And that's when I saw the tone of my conversations really beginning to shift. So it's not that all of a sudden all of our, Wisconsin drinkers were after a 15-minute brief intervention with me, were saying, gosh golly, you're right, instead of a 6-pack during the Packer game, I'm gonna have milk. No. But what was happening was they were really we were going a lot deeper in that 15 minutes, and they were using that conversation as an opportunity to take stock, as an opportunity to say, hey, is this working for me? Is there stuff that maybe isn't working for me? Might I want to make some changes? And more patients were seriously entering into a conversation with me, and more patients out of that were making some changes. So that's when I really got convinced to motivational interviewing. It wasn't anything anybody taught me. It wasn't anything I heard in a class or a lecture. It wasn't the data and the statistics. It was that real world experience of trying some of this stuff out with the patients I was working with and seeing the impact that it was able to have. So I tell you that for a couple different reasons. Number one, because I want to let you know that I appreciate if you're sitting there with a skeptical mind thinking, who is this girl coming in telling us how to talk to our patients? We already know how to talk to our patients. I appreciate that. You already do. All of you have skillful communication. And I appreciate that, there may be some areas, if you choose, that you might want to try some of these things out in your own practice and see, does it work for you? Are you able to get results? I also want to tell you, this is a very brief introduction. Typically an introductory session in motivational interviewing is considered a day. And before we would expect anyone to get near what we consider proficient practice, like when we're looking at the research studies, they would have to have upwards of 3 days worth of training and some coaching, some individualized coaching. So there's no expectation that you're going to walk out of here an expert in motivational interviewing. But we hope that walking out of here you will. I don't know why that says two-part, because apparently I copied and pasted that part of it. But walking out of here you will identify what we call the spirit of motivational interviewing, or sort of our style and our basic approach. And we'll work a little bit on one of the core skills, which is reflective listening. So walking out of here, hopefully you would be able to do that if that was something you chose to do. And evoking change talk is one of our key strategies in motivational interviewing, and we'll talk about some ways to do that as we go. So just to get us started, I'm going to invite you to, I will read a statement that could be a patient statement, and I'm going to invite you to jot down on your paper, just in the margin of the slides or somewhere, what you think you might say next if a patient said this to you, assuming you want to be helpful, right? That's the basic assumption. Just what might you say next? I wish I could do something to lose weight, but it's not so easy. You're busy eating or you don't have a pen, you can formulate your response in your mind. I'm not going to be inviting you to share these. What we're going to do is take one, we'll look at it now, and then at the end of our time together, I'll give you a chance to revisit that phrase and see if your response might change in any way. Okay, so what is this motivational interviewing thing? Here's a definition. There are several definitions, but here's one. Motivational interviewing is a collaborative, person-centered guiding method. It's designed to elicit and strengthen motivation for change. We talk about motivational interviewing as being a guiding method, and the best way I've had that explained to me is that if we think about a continuum, where on one end we're very directive. And there are certainly times in your work, in your day-to-day work, when you need to be very directive. And that's where you're just telling someone, this is what you need to do. This is what needs to happen. And if we think about it, that way other end of the continuum is what we would call a following style. And that's where we think about maybe the more classic therapy example, where we're doing a lot of listening. There's a lot of it's really about the other person's agenda. They have sort of free reign to talk in a lot of directions that, and sort of do some self-discovery, and we're sort of there just holding the space. In that middle space between the two is what we call guiding. So with motivational interviewing, we are always very much in control of what's happening. We're not handing the reins over to the other person, but we are creating and shaping more opportunities for the other person to join us in an active way and also taking some control and being an active participant and more engaged in their care and in the conversation. Another way to define it, this is sort of my, like if you, layperson, if you just have to tell somebody what is it you're going to talk to those people about today, motivational learning is a way of structuring our conversations. And our goal is to help the other person talk themselves into making changes. That part, I find, for healthcare, is the biggest sort of twist. And that helping the other person talk themselves into change. Because we are very, very used to talking them into the change. That's oftentimes a huge part of our role. We can supply the reasons, we can supply the how, we can do all of that. And motivational learning asks us just to hold back on that a little bit. Okay, I recognize that y'all are eating lunch, and this is probably not usually the most interactive hour, but I'm going to push a little bit. We're going to do a little interactive stuff. So I hope you came able to go with me a little bit. So we're going to do an exercise, and this is a partnered exercise, and it's very brief. I promise it won't be too painful. So for this exercise, you just need to find one partner. Most of you are sitting right next to someone, so you can just turn to someone you're sitting by, and that person will be your partner. And there's going to be two roles in this partner, person one and person two. So your first task with your partner is decide which of you is one and which of you is two.
It could be one.
All right, everybody ready? Okay, so person one, your role in this activity is to make a fist. And my only instruction to you is that this is your fist. And throughout this activity, you can do with it what you want. You're totally in control of it. It's yours. Okay? The only thing, I do have to say a caveat, and I say this especially to this group because the last time I did this with a group of physicians, one of them, not too hard, but that's the, please don't physically clock the other person with your fist. Other than that, it's your fist. You're in control of it. Person number two, your job in this activity is to try and get your partner to open their fist using only the power of conversation. Okay, so no bribes, threats, no physical force. Try and talk to them into opening their fist. Okay? So we'll just take a few minutes. Go ahead and get started.
Sure. You talk money.
I can't find me.
No
Why are we such because I missed that first
This is the perfect.
Okay, got about 30 more seconds.
Henry, you're gonna fail this. You're gonna lose your grade.
and if we're arguing about a test, I want you to take your point. I want them to see that and then they become slowly learning. Oh, that you're doing.
Okay, I'm going to interrupt. Some of you are still working hard on this. Some of you are done. If you were person number one, so if you had your fist and could do with it as you wanted, what did you notice in that activity? What stood out to you? either about what you were thinking, what you were feeling, what it seemed like your partner was trying to do, how that interaction felt.
And I look at the fist as kind of a threatening type of a thing. Like, why would I want to make any change? Don't talk to me into changing because I got my fist here if you say the wrong thing.
Yeah, it felt like a defensive, like a wall up, sounds like. Yeah. What else? Other folks? Okay, how about on the flip side? If you were in the position of trying to talk them into it, how did that go? What did you notice happening between the two of you? What worked? What didn't work?
They seem very focused on keeping that closed.
So your partner seemed like all their attention was really focused on, I'm going to keep this fist closed. Other folks, same, different? So you just hands off, very laissez-faire. And did he leave it or did he open it? Then he opened it. Okay. So you sort of reinforced his ownership of that. You didn't try to use any coercive power to teach or educate or anything. You just, okay, it's your choice. And then that seemed to relax some of that tension.
The sense, they're not in a receive mode. It's like, oh, this is...
Yeah, it just felt like anything you tried, they were not ready for that at all. Yeah. It's amazing to me when I do this exercise, how many times, I never tell person number one, your job is to keep your fist closed. But lots of people interpret it that way. I did everything I could to just not open that fist, even though my partner was saying some effective things. And it's amazing how when we get a little bit of power, when we're in a situation where we feel vulnerable, you probably weren't feeling super vulnerable in this activity, I hope, but when we get a little power, it's important to hang on to the things we can control. So thank you for bearing with me on that exercise. All right. So why would we use motivational interviewing in healthcare? This isn't probably what you went to school to learn. It's not the stuff you focused on. But we know that unhealthy lifestyles and behaviors contribute to a huge portion of chronic diseases, suffering, death. And we know that people's level of motivation and efficacy are good predictors of positive change. So when we're working with someone who wants to change, if they seem to have higher levels of motivation, higher levels of self-efficacy, they're likely to change. And we know from quite a bit of research that provider style of communication and provider approaches can influence adherence and outcomes. Also, what we know from the research is that when motivational interviewing approaches are implemented, patients express greater satisfaction with the providers. You're always looking to increase those patient satisfaction rates. And providers report feeling more effective, and secondary to that, less burnout. So typically in healthcare, we like to give advice. What we know is that over half of patients do not follow the advice of their healthcare provider. Particularly challenging are lifestyle modifications focused on diet and exercise. Over 80% of patients do not follow those recommendations. Does that seem true to your experience? If I said 80%, does that kind of pass your sniff test? Yeah, maybe higher. Medication, we know only about 40% of patients take their medication. 40% of patients don't take their medications correctly, and they don't take them at all. And one particular study found that even after a myocardial infarction, only half of the patients followed advice to quit smoking. So lots of these things, our best advice, major life changes, we're handing them tools, don't seem to be the thing that can make that change for them or help them make that change. So we know that motivational interviewing is what's considered an evidence-based practice. There's a very strong research base underneath it. It first came about in the addictions field in the 80s. Since then, it's been explored in lots of different contexts and applications. There have been over 300 randomized control trials. Last time I did a PubMed search, there was like over 1,800 citations of motivational interviewing. We know that in most studies, it outperforms information giving and advice. And it is something very concrete. So we can look at someone's practice and assess how well they're doing at motivational interviewing. So it's something that's very much in the hands of the user to increase their skillfulness. We also know that it plays well with others, I like to say. It works really well in combination with other things. It's not an approach that's so rigid that you can't use other approaches in addition to it. You can't marry it with other approaches. So some very basic concepts in motivational interviewing. The first one being empathy and unconditional positive regard. That's a kind of a therapeutic term that just talks about we hold the other person in esteem and value no matter what choices they're making in the moment, right? And we know that those two, us approaching the other person, the patient, in that way is helpful for patients in recognizing, exploring, and resolving their ambivalence. Ambivalence is often a part of the change process. That's just that, feeling two ways about stuff, having arguments on both sides of it. If we look at the question that I gave you for our initial sort of take one, I wish I could do something to lose weight, but it's not so easy. So on one hand we have the I want to, on the other hand we have the it's hard. That's ambivalence, right? And so helping patients explore that and resolve that ambivalence can help them make positive movement toward change. We also know that motivational interviewing, one of its main approaches or strategies is to elicit and reflect and try to grow what we call change talk. And that is just our term for the other person's arguments for change. So we know that when someone gives voice to their own arguments for change in an interaction, the likelihood of them walking out the door and in their real life actually making the change increases dramatically. Now, there's some very curious thing going on, because even if they have those reasons in their brain and don't say them out loud in an interaction with another professional, they're not as likely if they don't say them out loud. So there's something about saying them, and there's something very powerful about that being in relationship with another person and saying it to the other person. So just, me sitting at home alone and thinking about my list of reasons why I should make a change, that's powerful. But it's nowhere near as powerful as me being in conversation with someone that I have a trusted relationship with, who's showing me respect and empathy and saying those things to that person. So motivational interviewing really mobilizes our commitment. So once we've got some motivation, we have to consolidate that into commitment. And it helps us, we start with the why, right? So there's a whole TED Talk and a lot of in the pop culture, this idea of start with why. I don't know if any of you have heard Simon Sinek. He's a businessman, basically, talking about, we should start with the why. And he has this whole scheme. But it really makes sense. And if you think about how we approach behavior change in healthcare, often we start with the what and the how, right? So we tell the patient, here's the change you need to make. And we might tell them some whys, but we don't do a lot of it helping them explore their own why. And often then, when they get stuck, our strategy is to go to how, right? We'll give them some coaching, we'll give them some more tools. And what this model says, which is maps onto motivational interviewing very nicely is that we have to start with the why. When people are motivated, they can and do overcome all sorts of obstacles. Huge obstacles. People can and do make difficult changes all the time. And they do that because they are connected to the reason why they're making that change. They do that because they know their why. And they stay connected to it throughout those hurdles in the road. So one of the things we encourage, and we work on this a lot when we're coaching health professionals, is to avoid what we call the expert trap. So when you are busy being the expert, telling the other person all the things you know about why they should lose weight, there's often not enough space in the encounter, in the relationship, in the visit, to hear their reasons why they might want to lose weight. So we encourage people to, as hard as it is, and this is something I still struggle with as well, take that expert hat off, set it aside for a moment, and let the patient be the expert first. And let them explore their own stuff, and try not to fix it for them. Because generally when we fix things, when we try too hard to fix things for other people, we find that number one, it's very disempowering, because it says to them, I can fix it, and I'll do that for you. As opposed to, you can fix it, I'm here to help, I'll guide you, I'll support you in that. A couple more basic concepts in motivational interviewing is that there's no wrong source of motivation. Okay? I find this a lot. We in healthcare want people to change for the health reasons, right? That makes sense. That's what we know. That's the sort of value set we're operating under, and that's the approach we're having. I had a patient once who told me, I couldn't care less about what drinking is doing to my body. It doesn't really matter. I'm going to die from this or something else. But when I sat down with him, he was willing to engage and talk with me still, which was very curious. And when I sat down with him and we did a little calculator to look at how much he was spending on alcohol, and he added it up and realized that in the past year he had spent the amount of money that he could have used to make a down payment on a house. And this was someone who was living in pretty far below the poverty line as it was. And when he had that realization, that was his aha moment. For him, he was like, seriously, in the last year, I drank away that much money. And here I am scrambling to pay rent every month. And this person wasn't, he wasn't addicted to alcohol. He wouldn't meet that criteria. He was just a heavy drinker, and his life was pretty hard, and he enjoyed his alcohol. That was his recreation. And he wasn't going to stop for all the reasons it was ravaging his body. But when he figured out, if I, instead of stopping at the bar or stopping at the corner liquor store, banked that money, next year I could be buying a house instead of struggling to make rent from my landlord. That was it for him. And he cut way back. He didn't quit drinking, but he cut way back. And following up with him a couple of years later, he had moved into a pretty stable housing situation. He was living a very different life because of that aha moment. And for him, that was the thing that was motivation. So I remind people that there's no wrong source of motivation. We want them to change for the reasons we want them to change, but it's okay if those are just the secondary benefits. So it's important to discover what's important and what matters to the patient, and look at, where's that space between how you want things to be and how things are right now, and how could some changes help span that gap. So when we do want to, or need to in our role, share information or advice or guidance, there's a couple key steps that we want to do to make sure we're doing it in an MI way. So there's this 3-step process, very fancy terminology for it. It's called ask, tell, ask. Right? So instead of me, say I have some suggestions for a patient, they've been working on losing weight. And I want to give them some suggestions. Here's some things you could try. Before I jump in with my expertise and my advice, first I want to ask them, what things have you thought of trying that maybe you haven't tried yet? What ideas do you have? Let them share their expertise. They may have had the same ideas that I'm about to tell them. Letting them say it helps them own it more. It helps it be their idea instead of our idea. And it helps them be more likely to take action on it. It may be that they are truly fresh out of ideas. And then we can get their permission and say, well, I have some ideas, would it be okay to share them with you? Or maybe they have some ideas, but we think ours would also be a good complement, and we want to add to their list of ideas. Either way, we just ask a brief permission. Would it be okay if I shared some additional ideas with you? Share the ideas. And then, so that's the tell part, the share the ideas. And then the ask. What do you think of those? Which of those seems like something you might want to try? How do those sound to you? Okay. So get them to make some meaning with the information and not just, sort of drive by and drop the information and leave kind of thing, but help them in that moment to apply it. That's going to help it stick a little more. So our typical healthcare encounter uses what we call the deficit approach. This isn't necessary. Deficit sounds like unnecessarily pejorative, I think. But this is how we're trained. We're trained to come in and identify the problem. What's wrong? Right? What's going on here? So when we have a patient who's not making necessary changes, we come in with this approach. What's the matter? The implied thing that some patients hear from that is what's the matter with you. But really we're looking for what's the matter. Does the patient not know? Maybe they don't understand. Maybe they don't know how. Maybe they're lacking resources. Maybe they just don't care. Maybe they're in denial. We got to break through that denial, right? So making those assumptions about what the matter is shapes our role. Because then our role is to educate, inform, twist their arm as much as we can, and provide them with the answers. The message this approach sends to patients is, I have what you need, and I'm going to give it to you. And so motivational interviewing just asks us to try first this competence approach. So instead of asking, what's the matter, we're asking what matters, right? So what's important to this person? What is motivating them? What are their values? What strengths are they bringing in? What past experiences have they had that might help the matter at hand? And then that shapes our role to be very different. We're there to help, to listen, to ask good questions, to try to understand, reflect themes. That doesn't say we can't ever offer suggestions or link them to resources as well, but that's just not our primary goal in that moment when we're talking to them about that really sort of intransient, stuck change. So the message that sends is, you have what you need and we'll find it. Okay? So it's a much more empowering approach, and the result of that is a much more activated, engaged patient. And that's what we want when we're talking about lifestyle changes, when we're talking about managing chronic conditions. We want the patient to be activated. We want them to be engaged. We want them to take ownership over that process. Because gosh, it's exhausting when we own that process. When we own the responsibility for the change and the how and the when and trying to make them do the why. That's exhausting. That's hard. And it doesn't work. So all those things together kind of make me think, let's try something different, right? So this, I can tell you some patients will wonder if you approach, if you shift and use this kind of an approach, because they're not used to that. Sometimes I hear patients say things like, well, what is the right answer? You're the doctor, aren't you supposed to tell me? Right? Well, it's reasonable that they would expect that because we've spent, 50 years training them, 50, 60, 70 years training them that we're going to come at them like we have all the answers and we're going to tell them what to do and then they can go home and do whatever they were going to do anyway. That's sort of the relationship they expect. So we're changing up the game a little bit. And my response when people say, hey, why are you asking me? Don't you have all the answers? aren't you supposed to tell me what I should do here? I usually say, gosh, it would be really nice if I just had all the answers to fix this for you. I wish I did. Ultimately, though, I can give you my best advice, I can give you some suggestions, but you're going to have to decide what works best for you. So when we talk about the spirit of motivational interviewing, it's really just our fancy way of saying the style of motivational interviewing. And we talk about partnership, evocation, so that's drawing it out, getting the other person to contribute more, compassion and acceptance. And one way that we kind of can demonstrate, one particular strategy or tool that we can use to demonstrate a little bit of that partnership is agenda setting. So this is a tool, it's very flexible. I love this approach because you can use it if you are in sort of a more structured program and you're meeting with someone like for an intake, or if you're meeting with them and it's somebody you see regularly, you know, you've been their primary care physician for a long time, or if you're just meeting with them one time and this might be the only time you meet with them. So you can change a little bit about the structure and still use this approach. The basic thing in this approach, it's called agenda setting or agenda matching, is that I own part of the agenda and the other person owns part of the agenda. So usually, if this were my, this one is from a falls prevention program that I worked on. So this is what we developed with that. And it's actually a community paramedic. So an EMS person was going out to the home of someone who'd been referred, doing a risk assessment for the falls in the home and helping them get connected to more services and prevent falls. So the 4 things they always talked to patients about was food access, social support, looking for trip hazards in the home, and medications, right? So the way that this would be presented to the patient would be, you know, on this sheet, I've got a couple of the circles are filled in, and these are the things that I usually, as a standard, talk to everybody about, or the things that I want to talk to you about today. And you'll notice that some of them are blank, and we'll get to those in a minute. But first, I just want to tell you the 4 things that I want to make sure we find time for today are looking, you know, doing a little survey of your house and looking to see if there's any improvements we can make to make it a little more safe to prevent falls. I want to talk with you about, you know, the social support you have and the people in your life. And talk with you a little bit about meals and food and nutrition. And I want to talk to you a little bit about medications. Now you'll notice those 4 empty circles. Those are for you to tell me, what do you want to make sure we get to today? And so then they add on whatever it is. So this one's very strategically structured because they decided they wanted the patient's ideas and agenda items to be centered in the middle of the page. You know, I've used this when I have a 15-minute check-in with a patient to say, and I'll draw 3 bubbles on a page and say, here's the 2 things, 1 thing, 2 things I gotta do, what do you wanna make sure we do? We've got a short appointment today, we don't have a lot of time, I wanna follow up with you on your lab work, I wanna talk to you about the new medication we just started, what do you wanna make sure we also touch on today? Right? So right out the gate, it helps them feel a little bit more partnered. And then, once I've got those 3 circles, I'll say, where do you want to start? Right? They're taking some ownership over the session. I'm going to still have to tightly control that time to make sure we get to all 3. But we can start with whatever. They might say, oh, let's start with the medication and just get that done. Or let me hear my lab results, get that over with. Or they might really want to talk about the 1 item that they added and do that first. But it lets them take an active role. We call it a partnership, right? But this is really actively making it a partnership. How do we structure the time? I do have to say, sometimes you have to be a little creative in how you group things because you might have a long list, right? So you might have to, you know, under the medications here, they're going to talk about what pharmacy do you use, how are you remembering to take your meds? Are you having any negative side effects? Are there meds you're not taking? Are you confused about your meds? You know, all of those things. But it's all grouped under one big category. So this is a tool that I like to share because it puts some of that spirit from the slide before, it puts a lot of these things into action right away. And doing it right ahead of time. What I've found is, if it is someone that I see over the course of time, the first time they may not have anything. They may say, I don't have anything to put it in, I don't know. You tell me what we're supposed to be talking about, right? Ask it the second time. They may have a similar response. By the third time, they're starting to know that I'm going to ask them to have an agenda item, and they'll have one, right? So it helps shape their preparation for the visit as well. It also eliminates some of that doorknob confession kind of things, because I'm asking them for it right away. Doesn't always. Sometimes they have to warm up. But it also, if someone starts talking then about something that's not in these four bubbles in any way, I can use that and re-ground us back to say, gosh, I'm a little bit confused. Because I thought we agreed today we were going to talk about these couple things. You're talking about this. I'm missing the connection. Or is it a new bubble that we need to add to our sheet? And it just helps us be very transparent about, rather than saying, let's get back on topic. It's a little less respectful. But this is saying, you may have realized that there's a more important agenda item that popped up. Do we need to add it and, save one of these for later? Do we need to maybe schedule a follow-up visit? That sounds like a really important thing. I think we're almost at time today. I think we should schedule a next appointment sooner rather than later, and let's make sure we discuss that then. It just helps us manage our time with them, again, in a more partnering way. So empathy is really important. It's a really important concept and skill in motivational interviewing. It's this idea of, trying on their perspective and really trying to get at their perspective. Some of you may have done that in the fist exercise. Some of you may not, right? I gave you each a role. Particularly those of you who are person number 2, I gave you the role of getting the other person to open their fist. Some of you may have thought about, gosh, it's probably not very comfortable to keep your fist like that. Some of you may have said that, right? And that's what we want to do with our empathy, is notice the other person's experience, try to understand it, and reflect it back to them out loud as a way of showing them our efforts to understand them and their perspective. In motivational interviewing, we talk about 4 main skills: open questions, affirmations, reflections, and summaries. We're only going to touch on reflections today. We have limited time. So a reflection is a statement, and it mirrors back to the other person either what they said or what they meant. We can demonstrate empathy very well with our reflective listening. It also shapes direction, and you get to choose what to reflect. So ideally, a reflection then sets the other person back up, because they're going to choose to either expand what they said, maybe refine it, because we got part of it but not part of it. They might correct our understanding. They might verify that, yeah, you've got that exactly right. They might emphasize or soften certain parts. Right? And there's 2 types: a simple reflection, which is what most people think of when they think of reflective listening, or when we teach active listening. This is what most people come to understand, which is just parroting back what the other person said. Right? So in this example, I don't know what I'm going to do. I really like drinking, but it's been a big issue lately. You could use a simple reflection to say, you don't know what you're going to do. Or you could say, you really like drinking. That one, they're probably going to tell us more about what they like about drinking. Or you could say, drinking's caused you some big issues lately. And they're going to tell us more about what those issues are. Right? So in our MI verbiage, this last part, it's been a big issue lately, that's their change talk. Right? That's where the motivation for change might be living. I got to hear what those issues are, where they are, what they're causing, more of that. Right? So our complex reflections is what we want to do more of in motivational interviewing, and this really does take some skill development, but it goes beyond what we said and tries to capture their meaning. Right? So what might they be feeling? What are they intending with what they said? What's an interpretation of what they said? Maybe a metaphor. What do you think they might have said next? and they help us move forward. So the same thing, I don't know what I'm going to do. I really like drinking, but it's been a big issue right now. You're feeling really stuck and frustrated, right? That might be a reflection of some of the unspoken emotion. Or you're not sure what you're going to do, but you're really hoping we have some answers that we can figure out together. Or you're not sure if the issues are big enough to let go of the enjoyment. Right? So you're going to make some guesses, and you're luckily going to have some context clues when you have a real life person sitting in front of you. That's what more complex reflections look like. So we are almost at time. So I'm going to invite you to think about what is one or two things from today that's kind of sticking with you, or that you want to stick with you moving out of this room. And then we're going to revisit our statement from the beginning of the day and just see if you might do or say anything differently in response to this patient's statement. I wish I could do something to lose weight, but it's not so easy. So just jot down notes for yourself if there's anything you would change, anything you might want to frame up differently. And that is what I had for you. I am here for questions. I don't know if there's any CE reminders anybody needs to give you before you scuttle out the door, but I'm here if anyone has any questions, or if anyone has any comments or things they want. I'll just be right up here as you work your way out and back into the rest of your day. Thank you for your time and attention.